Thank you for asking me to come today. So I'm David, I'm a haematology consultant and I do a bit of research on the side. I've been interested in CLL for the 20 years that I've been working in Hull. And before that, I was a lecturer at Liverpool University and did research into CLL there. And it's been fascinating and very gratifying to see how treatment for CLL has changed, and sort of unbelievable to me the treatments we have available now and just how fantastic they are. So in terms of my talk, this is what I'll try and address. If I lapse into sort of technical medical terminology, stop me. So John will do that, and I'll correct myself. But I'll talk a little bit about what CLL is, about how we diagnose it, about who gets CLL, when do we need to treat it, and how do we treat it when we do that. A little bit about what research is underway, and ultimately we will be able to cure CLL. So this is what we think of when we say CLL. So as a medical person, when people sort of talks about CLL, this is what we see. When we look down the microscope and to make a diagnosis of CLL, we look at blood, and when we see this down the microscope, then this is indicative of CLL. And what you can see is on the right, the large sort of purpley blobs. Those are the CLL cells. That's what's floating around in the blood and in the lymph glands and elsewhere in the body. And there's something about CLL cells that in the blood that make them quite brittle. So that when the scientists prepare this, so how this is actually done is there's a glass slide and someone puts a drop of blood on the slide and then scrapes the blood out so it's nice and thin and then stains it so I can look at it. And there's something about CLL cells that make them very brittle. And so on the left and right of the screen, there's like a big splat. And the medical term for the splats is a smear cell. And there's something about CLL that causes these smear cells to appear. And again, when you see that, that's almost pathognomonic of CLL. So 20, 30 years ago, this would be as far as we would go in diagnosing CLL. There'd be an abnormal blood result. Someone like myself would look down the microscope, we'd see this and we go, oh, that looks like CLL. But that's not an exact science. And so how do we diagnose CLL? Well, in about 80% of cases, it's diagnosed incidentally on a routine blood test. So someone goes to see their GP or see a specialist, and they have a blood test as part of monitoring the diabetes or the high blood pressure. And a blood test is done, and it's abnormal, and further tests are done to make a diagnosis of CLL. In a minority of people, CLL is diagnosed when tests are done because the person feels unwell. So somebody will go to the GP and say, look, I just don't feel right, I've been struggling for the past few months, I've taken time off work, or I can't walk as far when I go out with the dog, or I've noticed some lumps in my neck and under my arms, and my wife's told me to come. And so some people present with symptoms that are related to the CLL, and then the tests are done. And what symptoms do people present with? Well, we've already heard a lot about tiredness. Disabling tiredness is a feature of CLL. People can have sort of sweats, drenching sweats. Sweats can be pathological. But trying to decide whether sweating is abnormal or not can be difficult. So sometimes I'll talk to people and say, well, do you have abnormal sweats? And they go, yes, I'm a bit sweaty sometimes when I go walk the dog. That probably isn't pathological sweats. So pathological sweats is where somebody is just drenched through, often on the night. Sometimes we have people who are evicted from the matrimonial bed by the partner because they're so horrible and sweaty. That is pathological sweats, possibly related to CLL. Some people present with lumps in the neck, under their arms and in the groins from swollen lymph glands. That can sometimes be uncomfortable, sometimes be unsightly. Occasionally you'll get people saying, I used to be able to do my collar up, but I've given up because the neck's a bit swollen. Sometimes people can lose weight. people's weight will naturally fluctuate. My weight's naturally fluctuating upwards as time goes by. People's weight will fluctuate, but abnormal weight loss is really when you lose 10% of your weight or more over a period of months for no obvious reason. Some people have problems with recurrent infections. Sometimes the infections can be serious. If the CLL is affecting the ability of the body to make other elements of the blood, people can bruise abnormally. So what actually happens when the blood leaves your body? So someone takes the blood sample, it goes in a tube, off it goes into the ether. So the blood sample's taken, it then goes off to a haematology laboratory. So all hospitals will have a haematology laboratory that can analyse these samples. And it goes through a machine, and the blood count the blood is analysed automatically. And the machine's got a sort of a metaphorical red light on the top that goes off if any of the parameters are outside of normal. So in somebody that has a CLL, there'll be noted that there'll be an increase in things called white blood cells. That'll be flagged up. It'll be passed through to somebody there with a microscope. So this is the most implausible and unlikely slide element of my talk, in that I'm actually doing the work there. In reality, it's been my colleague at the back, Dr. Freiger, who'd be looking down the microscope. But then somebody would look down the microscope and see those abnormal blobs and splats that I mentioned. It's known that looking at blood samples and trying to make a diagnosis is inherently quite unreliable. So there are now more accurate ways, and the machine on the right, what that will do is the blood goes through it, and the machine looks for abnormal appearances of the blood cells. So the CLL cells that I showed in the previous slide, they've got an abnormal pattern of lumps and bumps on their surface, and you can sort of detect what those lumps and bumps are, and that tells you that it's CLL, or it tells you it's normal white cells or whatever. And then once the machine on the right has sort of said this probably looks like CLL, we can then go on and look at the actual the genetics of the leukemia cells. And there are various methods that we can do that. And the reason that's done is sometimes the leukemia cells are associated with genetic changes that are associated with a disease that's more stable, or a disease that's likely to be more active. And that process, that's all done usually within a week or two. The more advanced tests are all done in St James Hospital in Leeds. And from the blood leaving the person to getting all these sort of fancy results takes about a week or two, which is about as fast as it can be done. So the diagnosis of CLL is made when either there's an increased number of white cells in a sample that's taken for other reasons, or someone comes along with symptoms. And to make a diagnosis of CLL, you have to have more than a certain number of abnormal CLL cells in your blood. Below that level, sometimes we find people that have an ever so slightly raised white cell count, and the tests show that there are some CLL cells there, but it's at a very low level. And there's a slightly arbitrary differentiation when if you have more than a certain number of CLL cells, you have CLL. Below that level, you have a precursor condition that's called monoclonal B lymphocytosis, which people abbreviate to MBL. And this is viewed as all CLL comes from MBL, but not all MBL turns into CLL. And for MBL, no treatment is needed, no further investigations are needed. And most people with MBL, the abnormal cells sit there, sort of behave themselves, don't do anything. And the risk of the MBL going on to CLL that then needs treatment is less than 1 in 100 every year. So when we meet somebody with CLL, we've made the diagnosis, the white cells are increased, and the various tests have been done. The next thing we do is we think, well, what sort of stage is this at? And the reason that we do that is it partly drives what may happen in the future, and it partly drives the need for treatment. So early stage CLL is generally called stage A, and CLL that's moved forward a bit more will be called stage C. So people who have early stage CLL will have a normal hemoglobin level, so that means they won't be anemic or have mild anemia. There'll be plenty of things called platelets in the blood, and platelets are important for forming blood clots and stopping your bleeding. And there'll only be one or two, if there are any enlarged lymph glands, they'll only be enlarged in one or two places in the body, and they won't be causing any symptoms. For people whose CLL has moved on more and it's stage C, then those people may have anemia, so that might cause tiredness and low energy or more severe tiredness. It may cause the platelets to be low, so they may bruise more, or there may be lots of areas of enlarged lymph glands that are uncomfortable. For somebody who has stage A CLL, then generally a watch and wait approach would be advised. For people who have stage C disease, so who would probably have symptoms, then you'd be talking about having some treatment. And stage B is sort of by definition in the middle. Some people with stage B disease are monitored, some people need treatment. People who have stage A, early stage disease, many of those, like persons with MBL, it will stay stable. But over time, some people with stage A, the white count will go up, the lymph glands might start to swell. And so some people may go on and have what we would call progressive stage A. So who's affected by CLL? So we've already heard it's predominantly affects men, about 60%. The reasons for that are not well understood. And it predominantly affects people who are older. So this is data that's derived from Yorkshire. And so within Yorkshire and Humberside, there's a very good programme of data collection run by the York University. So everybody in West Yorkshire, East, North Yorkshire, Humberside, who has a diagnosis of a blood cancer, the data goes onto a database, and that is used partly for planning purposes, partly for research purposes, and also to inform policy. So what this shows is that the majority of people who are diagnosed with CLL are diagnosed in their 60s and onwards. So when you're diagnosed with CLL, you'd want to know what's going to happen. You know, as Michael said, people hear the word leukemia, and it's a devastating thing to hear. And people hear the word chronic. I've only learned relatively recently, maybe it's my sheltered upbringing, I've only learned recently that the chronic has very negative connotations. So they hear the word chronic and leukemia, and are obviously devastated. But the reality is people with CLL, many people never have symptoms from the CLL, and people who do progress to the point of needing treatment have treatment that is now very, very highly effective. And so the survival rates with CLL are excellent, certainly in relation to other blood cancers. So the top graph is telling us that after 5 years, the overwhelming majority of people are alive and living with the CLL. And the graph lower down is saying that, again, the majority of people are alive and well after 5 years. If you diagnose at an older age, your survival's not as good. That's not necessarily driven by the CLL, it's driven by the various health problems that can come along as you get a bit older. And also, if you look over time, you can also see that the outcomes for people with CLL and all blood cancers are steadily improving as we learn more about them and as treatment moves on. So when to treat somebody with CLL, who to treat and when? Well, the right answer is that it's when the person with CLL and the doctor have a discussion about the sort of the merits of treatment, the merits of monitoring. In somebody who's diagnosed because they presented with symptoms, or somebody who comes to me and they've lost a lot of weight, they've got lumps in the neck, they feel shocking, they've lost 2 stone in weight, the decision is quite easy. You're poorly, you need treatment, otherwise you're going to get worse. For somebody with clearly stable stage A disease, with no swollen lymph glands, you do the blood test a few times, the blood count's not changing, then the right approach is to sit and monitor. And I'll explain why that is in a bit. It can be difficult sometimes in people who are feeling well. You know, I get people that come to me and say, I feel well, Dr. Allsup, I feel great. And they often labour the point a bit by, I went to the gym this morning, I feel great. I swam 50 lengths in the pool, I feel great. And so that's fantastic. But when you look at the blood tests, each time they come, the white count is going up and up and up and up. And the telling sign I've found is when someone's going, I feel great, Dr. Allsup, is there's a partner staring at them, looking daggers. And then they look at me and look daggers at me and look at the partner again with daggers. And that's one of the key signs that something's not right that I've found. But it can be difficult when people genuinely feel well, the white count's going up, the disease is clearly progressing. It can be difficult to call the point at which you say, look, great you feel well, but if we leave this much longer, you're going to sort of wind up on my ward downstairs with problems. And calling the point at which to offer treatment in somebody who feels well but has got progressive disease can be difficult. And when not to treat. So someone who is clearly asymptomatic, has no symptoms, has stable stage A CLL, somebody with monoclonal B lymphocytosis, this precursor form, someone that has disease that is not causing any symptoms, but in whom the white count is creeping up. Sometimes there's a perception that when the white count gets to a certain level, you need treatment, and that's a sort of a view that's often sort of given by some clinicians. But there isn't in reality a level at which we would offer treatment. It's more importantly how the person is, are you getting on living your life or are you having problems? And it's more the kinetics of the change. So is the white count doubling very quickly? So does it go from 20 to 40 to 100 to 200 over a short period of time? People whose white count is slowly creeping up, it's 10, and then I see them a year later, it's 15, and then a year later, it's 17, and who have no symptoms, you can sit tight. There is a sort of a minor, it's like a mini industry amongst clinical academics and researchers and scientists in trying to do sophisticated blood tests to say who at the start will need treatment and who won't. So when we meet somebody who is asymptomatic and well, can you do tests that will say you will need treatment in 2 years or 5 years or whatever? And the answer is no, you can't. There are lots of tests that can say, well, you are more likely to have disease that's going to progress than the next person, but it's not an absolute thing. So at the moment, all these tests, these genetic tests that can be done, some people may have heard the word 17p or TP53 or other things. The presence or absence of these abnormalities, they can sort of guide your thought a bit, but they don't, at this point, they're not used for decision making. And then in terms of people who don't need treatment, what people talk about watch and wait. A lot of persons call it watch and worry. You're not doing anything. Why is that? You've said I've got blood cancer. Why aren't you treating me? And the reason for that is people have repeatedly tried to offer treatment to persons with CLL or asymptomatic with the view of stopping the disease progressing. So surely if you treat the disease early before it causes symptoms, surely that's got to be a good thing. And that's been tried, and what you can do is if you do treat people early, you can make the blood test better, you can reduce the white count, but you don't ultimately change what happens down the line with the course of the disease. And the problem is if you treat people at an early stage, some people you will slow the progression of the disease, but other people you will treat who would have never needed treatment, and you'll expose those people to toxicities of therapy that they would never actually have needed. And because our tests that say you may or may not have disease that progresses are imperfect, that's sort of why it's still a watch and wait approach. And also the treatments we have are fantastic, as I'll come to, but the prevailing wisdom is that CLL is still an incurable disease. And so again, if you're talking about offering a treatment that you might never need, that's non-curative, then again, that's why it's not done. Some blood cancers we look after can be cured with various chemotherapy approaches, and there the decision is much easier. So again, I've sort of mentioned a bit of this. As I said, there's a mini industry in trying to identify genetic abnormalities, what the leukemia cells look like, how lumpy and bumpy they are, and other things in the blood that you can measure to try to say, well, this is abnormal, this is abnormal, this is high, this is low, therefore you will need treatment, you will not need treatment. And it's still not fully fed through into clinical practice. And the other problem that we have with all this research, so all this research in saying, well, this might be associated with disease that's a bit better, this is a bit worse, is the treatments are now so good that the treatment basically trumps all these prognostic tests. The treatment works in people that have favourable and less favourable prognostic tests. But going forward, it may be possible, and it may be possible to identify who will need treatment when we first meet them, who has asymptomatic disease. And so there's a graph here, and the graph is showing the survival of people with CLL, and the blue line shows stage A CLL, and the dotted green line shows stage C. So the dotted green line would be people who'd be offered treatment because they have symptoms. But there's still, the research is there anybody in that blue line that we can pick out as somebody that will have disease that will progress and therefore will need treatment? So, how to treat CLL in 2024? So when I started as a consultant 20 years ago, we had two chemotherapy drugs really. We had a drug called chlorambucil and a drug called fludarabine. Both of those were imperfect, they had a lot of side effects, and could be difficult to use. The treatment landscape is now transformed so that chemotherapy is almost never used. And I can't think the last time that we gave chemotherapy to somebody with CLL. So if you're newly diagnosed with CLL in 2024, your clinicians will be talking to you about one of these treatments. And I'll expand a little bit on them as we go along. So there's a combination called venetoclax obinutuzumab. People abbreviate that to VO. Venetoclax is a tablet that's given every day for just over a year. And obinutuzumab is an infusion that's given periodically for the first 6 months of therapy. And that treatment is over and done with within about a year or so. There are other tablet-based treatments. There's a relatively newly approved tablet called zanubrutinib that's given twice a day. And that tablet is taken every day continuously until such time as either the CLL progresses or the person comes to me and says, Dr. Allsup, I'm not taking these anymore. So assuming that the disease neither progresses nor somebody decides they don't want to take it, then that tablet can be continued for many years. There's a similar tablet called acalabrutinib. There's a combination called ibrutinib and venetoclax. So both ibrutinib is a tablet, as is venetoclax. And as they're approved for use in the NHS at the moment, those two tablets are given for 15 months and then stopped. But there's clinical trial evidence and research that I'll come to that suggests we may be not doing that. There may be a different and more effective way to use that. And also you may be offered a clinical trial. So clinical trials are, by and large, most of the clinical trials in the UK at the moment are run by commercial drug companies. And they're usually comparing a new treatment versus an existing one. So an example would be comparing a new version of zanubrutinib, a new tablet therapy with ibrutinib, and some people get one and some people get another. Clinical trials are essentially the only way that collectively everyone moves forward. I've always been very keen on trying to open and offer clinical trials to people. Partly, as I said, it's the only way that we all move forward and learn more about the treatments that work. There is another advantage in that if you go into a commercial clinical trial where you may get access to a new therapy, by and large that metaphorically gives you another roll of the dice. So it gives you access to another line of therapy, another treatments that you may not be able to access on the NHS. And if you have treatment within a clinical trial, certainly a commercial trial, it doesn't normally prejudice your ability to access other NHS treatments down the line. But clinical trials, they have to feel right. So sometimes when I talk to people about clinical trials, people just doesn't feel right for them. People want the clinician to make a decision, or they want to jointly make a decision with the clinician, and the concept of being randomly allocated to one or other therapy doesn't feel right for them, and that's absolutely fine. And then for persons with CLL, who the CLL comes back after a previous line of therapy, then some of the treatments are similar to what's used initially. So again, the tablet ibrutinib or zanubrutinib or acalabrutinib. This tablet venetoclax given in combination with another infusion. And again, chemotherapy is almost never used. And again, clinical trials if they're available. Generally, if you've been treated initially with one type of drug, say something called ibrutinib, when the disease comes back, if it comes back, you tend to have a go at something different. So you tend to try and attack the leukemia with a drug that's not seen before, and then you try and rotate through different therapies that work in slightly different ways. So a bit more about these various types of treatments. So probably the most commonly used is this group of drugs called Bruton's tyrosine kinase inhibitors, or BTK. And Bruton was a doctor in the American Army in the Second World War, just after the Second World War. And Bruton described some children who had, or boys, who had a weakened immune system. And Bruton worked out that the reason that the immune system wasn't working properly is because some of the immune cells had a fault in a protein called BTK, Bruton's tyrosine kinase. And because there was a fault in this important part of the immune cell, then these boys couldn't mount a normal immune response. So it subsequently worked out that leukemia cells also have this same protein, this Bruton's tyrosine kinase, and it was worked out that CLL cells need to have this protein working normally to stay alive. And if you can switch it off or knock it down, then the CLL cells die. So that's led to a whole class of drugs called Bruton's tyrosine kinase inhibitors. And the currently accessible ones are ibrutinib, acalabrutinib, and zanubrutinib. There are some newer drugs that work in a slightly different way that gives them sort of theoretical advantages that are in clinical trials. There's one called pirtobrutinib and one called nemtabrutinib. And the pirtobrutinib we've used in clinical trial in Hull, and Leeds have also used it. And these medicines are all tablets. You take them every day, either once or twice a day, and you take them continuously. So you stay on the tablet and you just stay on it indefinitely. And these are highly effective therapies. A lot of people take them, have no side effects. Of people who do have side effects, the commonest is just feeling generally less well, a bit achy, it can cause joint pains. In some people, it can cause problems with raised blood pressure. With ibrutinib, about 5 to 10%, or 1 in 20 to 1 in 10 people can have a heart rhythm problem called atrial fibrillation. But the heart problems are less of an issue with the newer drugs in this class. The main issue with these tablets is that you have to take them indefinitely, and because they're so effective, people can be on them for 5, 10 years, maybe more than 10 years. The reason I don't know whether it's more than 10 years is we've only been using these medicines for that period of time. Another type of drug, or another approach, is with a class of drugs called BCL2 inhibitors. And the BCL2 inhibitor in common use is called venetoclax. And BCL2, again, it's a switch inside the leukemia cells that when it's switched on, it tells the leukemia cell to live and be happy and healthy. If you can turn that switch off, then the leukemia cell kills itself. So venetoclax is a drug that attacks this switch, switches it off, and tells the CLL cells to kill themselves. It's a very, very effective treatment, and is often given in combination with another drug called a monoclonal antibody. Venetoclax can be given either for a fixed duration of time, following which you have it for a year or 2 years and then stop, or it can also be given continuously. And generally, again, it's very well tolerated. The common side effects are just feeling less well, stomach upsets, and there is a very, very small risk of something called tumor lysis syndrome, which was a worry when doctors started using this. And the blessing and the curse of venetoclax is it's really, really effective, but it's so effective that if you give the drug at the usual dose, it'll kill all the leukemia cells off simultaneously, which is great. But when cancer cells die, they release all the gubbins that's inside them into the blood, and that gubbins can then clog the kidneys up and cause problems. So to mitigate this risk of tumor lysis syndrome, we basically introduce venetoclax very, very slowly over a period of 5 weeks. So we start on a sort of a homeopathic dose and then build the dose up and up and up and up onto the top dose after 4 or 5 weeks. And by doing that, you get rid of the risk of tumour lysis syndrome. But that causes the main problem with venetoclax. So to be able to build the dose up, you have to attend the clinic every week. You have to have initially blood tests before and after you take the tablet, and occasionally you have to come back the next day. Very occasionally people have to come into hospital for the first 1 or 2 times the dose goes up. And that means that for some people that means it's not right for them. And then in terms of other therapies, so we sometimes combine usually venetoclax, but also some of the other BTK inhibitors. We sometimes even combine that with a type of therapy called a monoclonal antibody, or a mAb, which is an intravenous drug. And what a mAb is, it's a synthetic, or it's a manufactured form of an antibody. So everyone's got antibodies in the blood. The antibodies help you fight infections. So when you get an infection, when you get a cold virus, your body will make an antibody, and the antibody is that sort of stylized Y on the right. And the antibody will float around your blood, and it will go to the virus, and it'll stick on the virus, and then in doing so, it sort of alerts your body's immune system that there's something there that shouldn't be there. So when the bacteria or the virus is covered in antibodies, the rest of the immune system kicks into action and gets rid of it. What was worked out about 30 years ago was that you can actually make an antibody that will target whatever you want. So scientists have made antibodies that target all different types of cancers. And so what happens is the antibody is given to somebody with CLL, it goes in and it sticks to the cancer cells, and in doing so, it alerts the immune system that there's a cancer cell there, and the immune system can have a go at getting rid of the CLL. It also makes the CLL cell a bit weaker and sensitizes it to other tablets that are given, like venetoclax. And also, it can say to tell the cancer cell to kill itself. So these again are highly effective therapies, usually more effective when given in combination. They're usually given on a weekly or monthly basis. Generally, they're well tolerated. Sometimes people can react to them. Sometimes when you're actually having the infusion, you become shivery and feel unwell. But they tend to get better after the first 1 or 2 times. They may increase the risk of infection because as a side effect, the antibodies will often sort of reduce the number of immune cells. So as I said, the outcomes for people with CLL are fantastically, unbelievably better than when I started 20 years ago. If someone had said to me 20 years ago, this is what will happen towards the, I won't say tail end of my career, but later in your career, I wouldn't have believed them. I said, you're joking, that will never happen. So it's unbelievable how things have moved on. Research has been done looking at persons treated with these new treatments in clinical trials and comparing their outcomes with what's known for everybody in a population. So the survival for everybody in the UK is known, the survival for everybody in America is known, survival and so on. It's all publicly available data. So when you compare the outcomes of persons treated with new CLL therapies to the outcomes of persons treated, of the whole population, very, very similar. There's a very, very slight difference. But it's saying that essentially if you have CLL and you're treated on these new treatments, your outcomes are very close to what they would be if you'd never had CLL in the first place, which is, again, unbelievable and fantastic. So CLL can make people feel unwell. We have swollen lymph glands, make you feel tired, and other problems. But CLL can sometimes sort of beget other problems in the blood. So CLL is known to do things to the immune system that knocks the immune system out of balance. And in doing so, that can sometimes trigger other problems with the blood. So sometimes when the immune system's knocked out of balance, it can cause something called hemolytic anemia. And what that means is the immune system decides to target the red blood cells, and the red cells are what carry oxygen and energy around your body. And the CLL can cause the body to break these red cells down more quickly than normal. That generally is treated either with tablets called steroids, But these new treatments, the ibrutinib and so on, are also effective treatments for this problem. Sometimes a similar thing can happen where the immune system will decide to start attacking platelets, and platelets are a bit of the blood that form blood clots and stop you bleeding and bruising. So sometimes the platelet count can sort of take a nosedive because the immune system decided to attack it. And again, that can be treated with steroids or with the newer therapies. Rarely, the CLL can change completely into a different type of disease called a lymphoma. And the name given to this is Richter's syndrome. And Richter, again, I don't know, he'd have been East European living 100 years ago or something. And Richter's syndrome is then treated differently. So what tends to happen in Richter's syndrome is somebody will be on treatment or not on treatment, and they'll come along and they'll say, oh, this lump's been getting bigger, over a period of days or weeks. And we'll do a test and we'll find that the CLL has changed into a type of lymphoma. And under those circumstances, different treatment with conventional chemotherapy will be required. This happens rarely. The incidence is variably quoted, but it's probably less than 1 in 20, maybe down to 1 in 50 persons with CLL this will happen to. Because CLL affects the immune system more generally, a knock-on effect of that is persons with CLL are at risk of other cancers. So you need your immune system to be working well and normally to suppress the cancers. So if say part of your skin, an element of your skin, a cell in your skin starts to become cancerous, then the immune system will often spot that, and the immune system will clear up any emerging cancers or some emerging cancers. And it's been known for decades that people who have low immune systems for a variety of reasons are at risk of other cancers. And the common ones that people can get are skin cancers from sun exposure and also lung cancer from smoking. And because of this effect of CLL on the immune system, it can also increase the risk of other infections that we're going to hear more about, I think, after lunch. So CLL is associated with infection risk because of what the leukemia does to the immune system. Most of the infections are viruses, because that's most of the infections that are around, and include flu, the common cold, COVID, and other things. Sometimes people can have infections with bugs called bacteria, for which you might need antibiotics and other rarer bugs. Vaccination may reduce the risk of serious illness, and again, we're going to hear more about that in a bit. And also an increased risk of infection can be associated with some of the treatments we use. So even the newer therapies, which are excellent, may increase the risk of some infections. However, conversely, the risk of infection may go down and the immune system probably recovers if you have effective treatment, which you would have, and the leukemia comes under control and the immune system can recover. And the experts talk about something called immune reconstitution, where the immune system recovers. It's like building your muscle up after a period of being less well. So how to reduce the risk of infection? So being fully vaccinated, having all the vaccinations for which are offered is very important. Some people who have severely weakened immune systems, they can sometimes benefit from either taking antibiotics on a regular basis, or sometimes our colleagues called immunologists who are experts in the immune system, sometimes they can actually give something called immunoglobulin, which replaces what the body's not making. And immunoglobulin is natural antibodies that's given by an intravenous infusion or an injection under the skin. So in terms of research, CLL has benefited from extensive international collaborative research over many decades, and there is a sort of a vibrant and energetic group of scientists all over the world who've been looking into this, and the lines of research are predominantly around trying to understand why a CLL cell is a CLL cell. So what makes a CLL, what's turned some sort of healthy blood cell into a CLL cell? What's gone wrong? What switch has been closed or to what's kicked off in the immune cell to make it cancerous. And the idea is by unpicking all that, if you know what's gone wrong, then you can attack that with new treatments. There's also a lot of research going into, are some people inherently susceptible to CLL, blood cancers and cancer in general, and if so, does that then give you information about how you treat them? There's a lot of research into new treatments, so we've got lots of treatments already. We're approaching the point where we have so many effective treatments and so many effective treatment combinations that we don't quite know what's the right order to give them. So do you give drug A, then drug B, then A plus B, and then C, or what? How do you do it? And this is not a question that's answered in most clinical trials, but it's a question that comes up for all of us, for persons with CLL and clinicians. Do you give this first or that first? By giving one thing first, do you prejudice the chance of a good response to something else? It's basically unknown. And the big data research project that you're going to hear about from my colleague this afternoon is partly a start at trying to unpick, is it better to have this first than that, or the other way around, or does it make no difference? The clinical trials, the research has gone in the UK, so there's been a big clinical trial called FLAIR, and FLAIR I'm sort of involved with supporting and is run by the team in Leeds. And FLAIR was looking at conventional chemotherapy, a regimen called FCR, which is now historic. It was effective, but it's historic because of the side effects it caused, and comparing that to newer tablets called ibrutinib, and then ibrutinib combined with venetoclax. And FLAIR has found that ibrutinib is better than chemotherapy, and that giving ibrutinib with venetoclax is even better, and that if you give the ibrutinib and venetoclax together for longer than we're currently allowed to, and you do careful and detailed assessments of the response to that, then that may be a better way forward. Professor Hillman and Dr. Munir in Leeds are working with other people, Renata and others, to try and get this implemented into the NHS. There's the question about drugs like ibrutinib. So you're taking this tablet, you're taking it continuously. Do you need to take that tablet forever? So if you're on a tablet like ibrutinib and it's working well, are you best staying on it? Or is there a case for actually stopping it when things are going well and then restarting it when the disease becomes active again, and then going along with like a stop-start approach? And the rationale behind that is it gives people time off treatment. It may reduce the risk of side effects like blood pressure and other side effects. So the static trial is up and running, I think, in about 50 hospitals around the UK, and people who are on ibrutinib, who've been stable on it for some time, get allocated to either continue it or stop and start it. And the trial's being opened up also to another type of treatment called acalabrutinib. There's clinical trials going on around the UK looking at new tablet combinations. Does giving this new drug and that new drug together, is that better than what we've already got? There's a lot of interest in the issue around infections. Is there a way that you can actually switch the immune system on, make the immune system more effective to try and reduce all the problems with infections? There are new treatments coming through that would try and make the person's immune system attack the leukemia. So there's antibodies called bispecific antibodies, and they essentially bring the immune system to the leukemia and then make the person's own immune system fight the cancer. And then this is what everybody wants. We want to be able to get rid of this. We want to be able to meet somebody with CLL, say, okay, you need treatment, you have this treatment, and at the end of it, we can say, look, this has gone. You are cured. And we're not there yet. There's some people who have really, really good responses to some of the treatments we offer, in whom the CLL never comes back. And people will sort of hedge the bets and say, well, those people are functionally cured, which is sort of like a wishy-washy thing to say. It's sort of saying that we think there might be a bit of CLL still there, but you'd have to live to be 150 for it to come back and cause problems. What we want is to be able to cure it and say, this is gone, off you go. So maybe, and I think we're well down the way, and I think some of the work that the Leeds people are doing, the Leeds Trials Unit are doing, and also other units around the world, particularly some of the big American hospitals, are working towards this. It'll likely involve a personalised approach, trying to identify markers of response to certain therapies, and also very careful monitoring after the treatment finishes, and possibly more treatment to get rid of any CLL if it re-emerges. And it may just such an approach, may ultimately lead to cure, people being discharged, and putting the whole thing behind them. So in terms of CLL, I think we've heard quite a lot about this from John and Hilary and the other talks. How can you take control of the CLL? So sometimes there's a perception that it's a very passive thing. If someone comes and sees me, sits in front of me and listens to whatever words of wisdom I have, that's not how it should be. It should be a sort of a two-way relationship between the person with CLL and the doctor, and very much we want people to take control of the CLL, want people to feel empowered. And the way to do that is be informed, and the John and the CLL Support Association do fantastic work with that. Seek information from the various charities. If you get to the point of needing treatment, think carefully about what your preferences are in terms of treatment. Do you want to have a tablet and stay on treatment and continuously, or do you want to have a block of time on therapy and then stop? And you can discuss the merits of various approaches with the person, the clinicians looking after you. Very important to make sure your vaccinations are up to date. Vaccination is safe and effective. I've seen nobody have an adverse event from a vaccination that's caused them serious harm. I've seen people who've had problems with infections when they've not been vaccinated. Vaccination is a fantastic way to keep you healthy. Stay fit and healthy. So by looking after yourself, doing all the things that are known about to stay fit and healthy, that puts you in a better place should you ever get to the point of needing treatment. If you go out in the sun, use high-factor sunscreen, floppy hats, and under no circumstances smoke cigarettes. So if anyone out there smokes cigarettes, stop. Smoking is terrible, and there's something about CLL that makes it more terrible than it is for most people. So on that note, I'd like to close. As I said, I've been privileged to be working at the time when the outcomes of CLL have improved unbelievably. And thank you for your time.